So in this video, I'm talking about the interaction between functional activity and behavior and what's considered a pathoanatomical diagnosis, and how really paying attention to not just the pathoanatomy but also that functional behavioral activity can positively or potentially negatively impact a person. So the patient was a 16-year-old male, presented to physical therapy with a pre-surgical course of care package. So he was supposed to be seen prior to having a femoroacetabular impingement surgery, which was basically a labral repair and debridement, as well as the osteotomy in order to improve the range of motion that he had available. So I get the patient back, and through the subjective intake, I find out that he has pain only when he's playing football, and specifically while he's playing man coverage as a cornerback on the football team. When I move into the objective assessment, yes, he was positive for a lot of our labral tear or labral impingement tests. However, I noted that the range of motion in general was pretty good, and he had sufficient strength, could have benefited from some additional strengthening, but he had good strength. So things were not necessarily lining up with him having a true impingement because his range of motion was not limited. So at this point, I decide to put him through the motion. So I say, okay, let's see what in your covering of another player is reproducing your symptoms. So what we found out was symptomatic side. If I was playing the receiver, he was playing the cornerback. As he would backpedal and I would cut towards the affected side, he would cross over, ouch, and then follow me along. So that crossing over was associated with the symptoms. When we moved to the opposite side, he would backpedal and then he would open up and take off with me and easily be able to cover me. Now, what we ended up doing for that session was do a little bit of behavioral change. So I worked at 50% speed of him coming back and working on opening up, which is a less impinging position for the hip, and he had no pain with it. So the course of care for the next couple of weeks were for him to work with his coaches and work with his family in order to really rework his motor program, his motor pattern, so that when he was covering somebody, his tendency would be to open versus stepping across and closing off and reproducing the symptoms. Now, it was not a perfect transition. He had a lot of real life occurrences in that when you're playing football and your goal is to guard this guy or to cover this guy, that's dual tasking. He's not going to pay attention to this quite as much as something else that's going on. So he would still have intermittent symptoms, but he had a lot less symptoms now that he knew how to open, and he practiced that behavior. Now that he was aggravating the area less, his symptoms dropped down further because he wasn't basically picking the scab repeatedly over and over and over again every time he dropped into a man coverage. So ultimately, he ended up not needing surgery, and when we look at the costs associated with healthcare, he had substantially less cost because he didn't have the surgical intervention, nor did he have the post-surgical physical therapy. So in this case, we had what is considered a pretty standard pathoanatomical diagnosis. The range of motion subsequent to that time period, we have learned that the range of motion limitations are required for the true diagnostic label now. But for him, it was a simple behavior change. We just changed how he moved, and he had a substantial improvement in symptoms and course of care. So I hope that really hammers home the need to look at the pain behavior for your patients versus locking into potential pathoanatomical modeling.